Hi, welcome back to IU Radiology Case of the Day. My name is Tim Tsai, and I'm a fourth-year resident at the Indiana University School of Medicine. Today, we've got an interesting musculoskeletal case. I'd like to give a shout out and thanks to Dr. Meritz for his help, and of course Dr. Kuntz for organizing the entire Case of the Day initiative. I'd like to take a moment and emphasize that all the content in this presentation has been fully de-identified to protect patient privacy. Here, we have a 30-year-old patient with right hip pain. Here are the images. At the top left, we have a plain radiograph. At the bottom left, we have an axial non-contrast CT through the hip. At the top right, we have a coronal T2 FAT-SAT image. At the bottom left is a coronal T1 post-contrast fat-saturated image. Take a moment to inspect the images. Alright, now, what are the findings? What is your differential for this case? And what is your diagnosis? Let's go over the images. On plain radiograph, there's not too much going on other than subtle irregularity of the right hip cortical margins. I'd be rather hard-pressed to draw any definitive conclusions from just this image. On axial non-contrast CT, we see that there is a lytic, destructive right hip mass with cortical irregularity of the ilium and acetabulum. Thin arcs of calcific density are seen within the lesion, reflective of chondroid matrix calcifications. On MRI, this mass is lobulated and intensely T2 bright. The lesion extends down from the hip joint and involves the acetabulum. We can see abnormal marrow signal within the right acetabulum. After we added contrast, we see that there is irregular enhancement of the periphery and septations of the mass. Again, note the signal abnormality of the right acetabulum. This is a case of pelvic chondrosarcoma. Chondrosarcomas in general are the third most common primary malignant tumor of bone following multiple myeloma and osteosarcoma. It usually occurs in patients over the age of 40 and are rather rare in children. Pelvic chondrosarcomas typically involve the acetabulum in the previous region of the triradiate cartilage. It can also invade the hip joint, as in this case, and can have iliac adenopathy. Patients will present with hip pain, and radiographic findings can be very subtle, but CT and MRI demonstrates more dramatic findings. Pelvic chondrosarcomas are malignant and demonstrate aggressive features such as scalping and destruction of cortex, soft tissue and marrow edema, and periosteal reaction. They are large soft tissue masses with chondroid ring and arc calcifications. The nodules of hyaline cartilage result in its characteristic lobular shape, as well as the high T2 signal from its high water content. The differential can be rather extensive. In terms of chondroid lesions, enchondromas may come to mind. However, while enchondromas are common in long bones, they are very rare in the pelvis. In general, most large soft tissue tumors of the thigh and hip in older patients are malignant, so they should be high on the differential. Metastases are the most common malignant tumor of the pelvis, and multiple scattered lesions, as well as lesions suspicious as the primary malignancy, would make metastasis even more likely as the diagnosis. Myeloma and osteosarcomas are the top two most common primary malignant bone tumors, but the chondroid matrix argues against them in this case. Other sarcomas, such as malignant fibrous histiocytoma and fibrosarcoma, are not uncommon, but more so involve the iliac bone and proximal femur. They're pretty rare in other parts of the pelvis. Lymphomas, especially of the non-Hodgkin variety, are reasonable to include in the differential of a malignant appearing pelvic mass. However, their signal characteristics and propensity for adenopathy are rather different from chondrosarcoma. Tumor-like lesions can also result in aggressive appearing lesions of the pelvis. Infection and osteomyelitis are usually pretty distinct in both clinical presentation and imaging appearance compared to chondrosarcoma, but the notable exception is tuberculosis, the great mimicker. Sarcoidosis may present as multiple punched-out osseous lesions, mimicking malignancy. Hemophiliac pseudotumor could also present as an aggressive-appearing lesion, preferentially involving the iliac bone with bony destruction, new bone formation, and periosteal reaction. A history of hemophilia greatly aids in making the diagnosis. Synovial processes, such as rheumatoid arthritis and pigmented villanodular synovitis, can also mimic a hip tumor. However, the MRI characteristics are quite different, with pannus formation and hemosiderin deposition respectively. Pediatric patients have their own host of aggressive pelvic lesions, including Ewing sarcoma, Langerhans cell histiocytoma, and neuroblastoma metastases. This is a different patient population than that of patients with pelvic chondrosarcomas. For more reading on bone and soft tissue tumors of the hip and pelvis, I'd highly recommend this paper. So in summary, pelvic chondrosarcomas will present as high T2 signal lobulated masses, especially originating around the previous region of the triradiate cartilage. They have ring and arc chondroid matrix calcifications, as well as malignant aggressive features. Chondrosarcomas occur in older populations and are rather rare in children. Pitfalls include sometimes subtle findings on radiographs, for which cross-sectional imaging is more helpful. While the imaging findings and behavior of the lesion in this case was pretty characteristic, there is still a host of malignant-appearing lesions that can occur in the pelvis, and attention to patient history and demographics and the behavior of the lesion will help steer the differential in the right direction. So as always, thanks for tuning in to IU Radiology Cases a Day. You can follow along on Twitter at NAKuntz, and you can check out our complete collection of Case of the Day materials at the website below. Thanks so much and have a great day.